All right. Hello, everybody. My name's Lindsay. Again, I am the PGY1 pharmacy resident at OSU, and this lecture was created along with Dr. David. So today I'll be talking about hepatitis C, what lab information we need to get beforehand to evaluate the patient, and then briefly mentioning the different treatment options. And then in a couple of weeks, Dr. David will be talking more about the treatment of HIV along with hepatitis C. So let's get started. Nothing to disclose here, as well as here. We have our learning objectives stated here. So let's start talking about the epidemiology. Right now, hepatitis C is the most common bloodborne infection in the United States, and as much as 5.2 million people in the US currently have it. The scary thing is that 40 to 70% of people who are infected don't even know that they have hepatitis C. And mortality rates of people who have hepatitis C are greater than twice that of people who are not infected with hepatitis C. So this is showing what the rates are in Oklahoma. So approximately 54,000 people are currently living with hepatitis C right now. And you can tell on the bottom where it lists like the patients who might be infected, we're almost to like the severe category there. So this is showing you the progression of disease over time for hepatitis C. So we have a normal liver, we start out at the beginning, but then it gets infected with hepatitis C. And about 15% of patients can actually clear hepatitis C on their own. However, the majority of patients are going to end up with chronic hepatitis. And when it goes untreated, it goes into cirrhosis. So that would be about 15 to 30% of patients. And then 4% per year can develop HCC. And so this is one of the main reasons that we want to address hepatitis C, catch it early so that we can prevent patients from progressing into this. Because once you damage the liver, it's very irreversible. So if we can screen and be proactive about it, then we can prevent all these downstream effects. So continuing on, why it's so important that we treat it, because about 20% of patients who have hepatitis C will eventually develop cirrhosis. And hepatitis C is the #1 reason for both liver transplant and the main cause of hepatocellular carcinoma, or HCC. As well as these patients also have higher healthcare utilization, hospitalization, as well as prescription costs. And this is comparing the mortality rates between hepatitis B, C, as well as HIV. So you could see hepatitis B has remained relatively low, maybe slightly declining. For HIV, you can definitely tell over this course that it has definitely decreased. However, hepatitis C differs from those two, as like we are continuing to rise and have an increase in mortality rates. So this is another reason of why we want to catch it early. And so the goal of treating patients who have hepatitis C is to reduce all-cause mortality as well as liver-related consequences. And so we want to help prevent end-stage liver disease, HCC, and we can do this by achieving the virologic cure. So whenever we have a sustained viral response after the medication, we can consider a patient to be cured of hepatitis C. And I just think that this is one of the really unique disease states that we can actually tell a patient that they're cured. So being able to like have that impact on a patient is a really like rewarding experience that I've seen in clinic. So first off, let's identify which patients are at risk for developing hepatitis C. And so it's any people who inject or use intranasal drugs, have tattoos or piercings, who are currently in prison or were previously incarcerated, or children who were born to mothers who had hepatitis C. Also, patients who received infected blood products prior to 1992, or if they did have some kind of procedure in a healthcare facility that didn't have appropriate infection control practices. Also, people who have HCV infected sexual partners, as well as patients who have HIV is also an increased risk factor. So who do we need to screen? The recommendation right now is that anyone 18 years and older, it is recommended that we screen them. And it's only a one-time like screening unless a patient is at increased risk for hepatitis C. So we can have like hemodialysis as a risk factor or exposure. So maybe a patient who experienced like a needle stick in like a healthcare setting. So those would be indications as to why we would need to repeat testing in that patient. Also, it is recommended annually for people who inject drugs or HIV infected men who have unprotected sex with men. You would want to check for for hepatitis C every year. So this is the screening cascade and what we're going to do to see if a patient does have hepatitis C, kind of like what we talked about in our case. So first off, we're going to check the HCV antibody. And if it comes back negative, non-reactive, then at that point, you can consider a patient not to have hepatitis C. The only exception to this is patients who are immunocompromised because their body may not be able to create that immune response and create the antibodies. You can consider getting an RNA viral level. And then if a patient who was recently exposed to hepatitis C within the last 6 months, because it's maybe a newer infection, you can do a follow-up testing for hepatitis C RNA just to make sure that there's no viral load in their body. So going down the other side of the pathway, if the HCV antibody is positive or reactive, then that's whenever you get the HCV RNA viral level. And then depending on that, you're going to go down the different pathways. So let's talk about the viral load real quick. So the viral load is going to tell us the number of virus particles that are in a ml of blood. And this is going to confirm that a patient has an active infection. And we talked about this earlier, where up to 30% of patients can actually just treat or address the hepatitis C and clear it on their own. So they're always going to have that antibody, but their body just may not have any of the viral level. So why it's important that we need to get this viral load, it's going to tell us that maybe we could have a different duration of treatment. So for genotype 1, whenever we're using sofosbuvir and litispivir, that's whenever we can use like a different duration of treatment. And then this is also going to tell us whenever a patient is cleared. So they're going to be on the HCV medications for a certain amount of time. And then after that, we wait 12 weeks and then we check the viral load again. And if it is non-reactive, then we can consider that a patient has completed treatment and they have the SVR or sustained virologic response, and they are considered cured. The only thing is that this isn't going to predict liver disease progression. So if you see a really, really high viral load, it doesn't mean that they have like a worse case of hepatitis C. It's just showing us that it's there. So just keep that in mind. So back to our screening cascade, let's talk about if our hepatitis C viral RNA is not detected. That means that there's no current hepatitis C infection. And then the other option is that if the RNA comes back positive, that means that the patient does have a current HCV infection, and that's whenever we're going to go ahead and link them to care, work them up, and hopefully start them on the antiretrovirals. So let's talk about the workup. So these are all the different labs that you're going to want to get on a patient who has hepatitis C. So we start with a genotype. We have 3 main genotypes here in the United States, 1, 2, and 3. 1 is the most common and what we see mostly. However, 3 tends to be the more aggressive one and has like the increased risk of causing HCC. So that might be a talking point with patients who are maybe a little hesitant to starting treatment. If it's genotype 3, that we could talk about like the risks and the benefits to starting this medication to prevent that progression or increased risk of HCC. Additionally, we want to get a viral load, Hep A as well as Hep B serology. So for Hep A, you want to get the total Hep A total antibody or an IgG antibody. And if this is non-reactive, then patient needs vaccination. Then going on to the hepatitis B serology, we can immunize the patient if they are non-reactive. And we also want to monitor for reactivation upon the treatment of hepatitis C, because sometimes the hepatitis C can kind of keep the hepatitis B at bay. And once we get rid of the hepatitis C, then the hepatitis B has like a chance to reactivate. And so that would be a monitoring point whenever a patient's undergoing treatment. And those are all the different antibodies and antigens that you would get for a hepatitis B. Next, we're going to get a CBC. Looking at the platelets is going to help us stage what level of liver fibrosis the patient is at. With a CMP, we want to get the ALT and the AST also for staging liver fibrosis using our scores, APRI, as well as the FIB4 scores. And then also bilirubin if we're going to be calculating the Child-Pugh score. Also, you want to get their HIV status because we know it's important to treat that. And then if we're treating both HIV and hepatitis C, keeping in mind the drug-drug interactions that can occur between the two. So let's talk about our treatment options. We have our DAAs, or direct acting antivirals, and each medication is a combination of 2 or 3 medications from different classes. And so our NS5Bs, they all end in buvir, NS5A inhibitors end in Asvir, and then our protease inhibitors end in Previr. So these are our 5 different options that we use to treat patients with hepatitis C. And so not all of the medications are going to treat all of the genotypes. And so one thing that's easy to remember, genotype 1, each of these medications is going to work for each of these for genotype 1. So you don't have to like worry about which one is going to cover that one. And then these 3 medications cover all the genotypes. So Epclusa, Vosevi, and Mavorite. You don't have to worry about like which genotype they have because it's going to cover all of them. And now this is the common first-line therapies in a patient who is treatment naive. It can get a little complicated once you go down the pathway of whether or not a patient has been treated and failed therapy before. In that case, you might have to get some like resistance testing. But this is just for a patient who is treatment naive. So looking at our first column here with a genotype specific, so we could use Zepitir, and this is going to be a 12 to 16 week regimen, 1 tablet daily. Genotype 1 or 4, and sometimes you might need to use ribavirin in certain cases. But the advantages of this one, it can be used in end-stage renal disease as well as patients who are going to hemodialysis, but then you want to make sure to not use in decompensated cirrhosis for this one. Then moving down to Harvoni, again, this one is genotype specific, 1, 4, 5, or 6. You can use this for 8 to 12 weeks, 1 tablet daily. This one does have an interaction with proton pump inhibitors, and so we would want to avoid patients who need to be on that, or we can counsel them to not take it while they're undergoing treatment. Again, it's only 8 to 12 weeks, so I feel patients are really understanding that just having to sacrifice a little bit can eventually like save their lives. So again, also can be used in end-stage renal disease, and these ones can be used in decompensated cirrhosis. Now looking at the genotypes that work for all of them are pangenotypic. So genotype 1 through 6, we can use Mavorite, and this one is 8 to 12 weeks. And this is 3 tablets daily with food, and this one also does have the proton pump interaction. And again, don't use in decompensated cirrhosis. And then for Epclusa, this one's 12 weeks, 1 tablet daily, again with the proton pump inhibitors, and this one can be used in decompensated cirrhosis. So the 2 that I see most common is going to be Mavorite and Epclusa, and it really depends on patient factors as well as their insurance, which one we can get approved. A lot of time we have to use the patient assistance programs through the manufacturers to get these medications covered. Another one, patients who are on Mavorite have to take it with food. So if access to food or they have just a small appetite is an issue, then that would lead us more towards Epclusa. So looking at the drug interactions, always look and do a drug interaction check before you start any other medications along with the hepatitis C. LexiComp is a great resource. And then we also use the University of Liverpool hepatitis C drug interaction checker. And this has generally like the most up-to-date information on hep C interactions. And it also gives you like alternatives, which I really like, that may not interact with our hepatitis C medications. So in conclusion, treating and curing hepatitis C can decrease the incidence of cirrhosis and HCC. It is important to screen everybody who's over the age of 18 and above. We can repeat a hepatitis C antibody if it is indicated, like immunocompromised patients. It doesn't take a specialist to treat hepatitis C, and there's a lot of treatment options available. So looking at the guidelines for the most recent recommendations, and then always being like having the opportunity to present your cases here at ECHO to see what everyone has to offer. Here are the references, and that concludes my presentation. What questions do you guys have for me?